Gastrointestinal disorders, pathophysiology, and disease correlation. So just an overview of the GI tract. It's an 8-meter tube beginning at the mouth, ending with the anus. Major organs are the stomach, pancreas, small intestine, large intestine. It is drained by portal blood vessels, and absorbed substances are transported directly to the liver. There are 3 phases of digestion: the cephalic, gastric, and intestinal phases. Cephalic phase is the neurogenic or vagal phase. We call it the vagal phase because it involves the vagus nerve. It's initiated by sight, smell, or taste of food. Stimulate the cerebral cortex and the vagus nerve. Gastric phase is initiated by distension caused by food entry into the stomach. So while cephalic happens when you just smell food or you're looking at food, sometimes even when you're thinking about food, the gastric phase doesn't happen until it actually enters into the stomach. It stimulates the release of hydrochloric acid, which causes the direct stimulation of parietal cells by the vagus nerve, local distension of the antrum, stimulation of gastrin production by the vagus nerve, stimulation of gastrin production by neutralization of gastric HCl by food entering into the pyloric zone. Gastrin. So we're going to talk quite a bit about gastrin throughout this lecture. In the gastric phase, gastrin stimulates antral motility, and that's talking about the motility of the stomach as it churns to break down food. So the rhythmic movements of the stomach to break food into smaller pieces. Secretion of pepsinogens, pancreatic fluid rich in enzymes. Pepsinogens are going to break down different things that are ingested through the digestive tract. Release of GI hormones, secretin, insulin, acetylcholine, somatostatin, pancreatic polypeptide. Food is then mixed with gastric secretions and becomes chyme. Chyme from the stomach is going to leave the stomach and enter into the intestine. Now there are 3 parts to the intestine: the duodenum, jejunum, and ileum. The duodenum is a pivotal portion of the small intestine because all of the pancreatic enzymes are going to dump into the duodenum. This begins the intestinal phase. So it's initiated when weakly acidic digestive products enter the duodenum. Pancreatic juices enter the duodenum through the ampulla of Vater and sphincter of Oddi. Carbohydrates digested by amylases, saccharides, and saccharidases. Protein is digested by pancreatic and intestinal enzymes. And dietary fat is emulsified by bile and hydrolyzed by lipase. Emulsified means that it's separated. So when you have something hydrolyzed means you break apart using water. Hydro is referring to water, lysed or lysis is referring to break apart. So lipase actually breaks apart the bonds within the fat, while bile surrounds the fat molecules that are broken apart to prevent them from going back together. Remember, in an aquatic environment or a water-rich environment, fats are uncomfortable. They want to find each other, clump together, and get away from the water as much as possible. So in order to prevent them from coming back together after lipase breaks them apart, we need to surround each fat particle by bile. The digestive process ends with the formation of feces in the large intestine. So this table is really important because it gives an overview of the different hormones and their function related to the intestinal phase. So gastrin is going to cause an increase in production of gastric acid. It increases gastric motility and the growth of small intestine mucosa. Cholecystokinin increases gastric secretions, pancreatic function, gallbladder contraction, and intestinal and stomach motility. Secretin is going to increase gallbladder contraction, pancreatic secretion of bicarbonate. It stimulates pepsinogen production. And then it decreases the gastrin gastric acid secretion and gastric duodenal motility. Gastric inhibitory peptide decreases gastric acid, gastrin, pepsin secretion, intestinal motility, and it increases insulin secretion in the presence of hyperglycemia. So if there's a lot of glucose present, it's going to increase insulin secretion. Vasoactive intestinal peptide. It's a potent vasodilator. It aids in the relaxation of smooth muscle, a large number of physiological functions, including increase in water and electrolyte secretion. Somatostatin inhibits most GI, secretory, and motor functions. So this is where you can see where they are most active in the stomach, duodenum, jejunum, ileum, and colon. And you can take a look at where these different hormones are active. Absorption occurs in the small intestine. Carbohydrates are absorbed by active transport into the bloodstream. Proteins are absorbed as amino acids, dipeptides by specialized absorptive mechanisms. Digested lipids enter into the intestinal cell as micelles, so the components actually go right into the intestinal cells. Fatty acids or monoglycerides diffuse into the intestinal epithelial cells, and the fat-soluble vitamins are absorbed with lipids through the intestine. From there, they're processed and packaged into chylomicrons, and those chylomicrons are actually dumped into the lymphatic system, where the lymphatic system has the cisterna chyli, which is then going to collect all of the fats from the small intestine, and it's going to dump them back to the liver. And from the liver is going to process them and turn them into transportable lipids. So they're going to attach the lipids to lipid transporters and transport them. The liver is also going to metabolize many of these substances. So carbohydrates, proteins, and lipids all end up in the liver for metabolism. So now getting into some of the gastric diseases. Ulcers. So ulcers result from the loss of normal internal or external surface of the body. In the GI tract, most commonly found in the stomach or duodenum. They most often caused by excess acid. So peptic ulcers refer to that excess acid in the stomach. Chronic duodenal ulcers and chronic benign gastric ulcers are categorized under peptic ulcers. The causes are multifactorial, but there are some risk factors. So having group O blood or blood group O, local, so decreased mucosal prostaglandins damage the mucosal lining, or infection, Helicobacter pylori. Definite diagnosis is based on morphological diagnosis. Identification of H. pylori infection in patients with dyspepsia or stomach pain while eating. Serological tests can aid in the detection, so we look at antibodies that are forming against H. pylori. Then we can detect urease in the stomach through the urea breath test. The patient ingests a meal containing 13 or 14 carbon, radioactive carbon. Then we measure the amount of the isotopic carbon that's in the breath. It's highly sensitive and specific, about 99% in untreated patients. In gastric biopsies, we do a direct urease test and the CLO test. Detection of the antigen in feces is also performed, so we'll take a fecal sample from the patient and look for the antigen in the feces, although it's not very sensitive. And then when patients do not respond to antibiotics, we do a bacterial culture. Zollinger-Ellison syndrome, so also abbreviated ZE syndrome. This is an extreme form of peptic ulcer disease. It's characterized by recurrent peptic ulceration, often accompanied by diarrhea. So what's characteristic of this disease is you see an increase in acid and increase in gastrin. The most common causes of ZE syndrome include a gastrinoma. Gastrinoma is a gastrin-secreting tumor of the pancreas. An antral G-cell hyperplasia of the stomach. So as we learned previously, hyperplasia is an increase in the number of the cells. So we're talking about increase in number of G cells. Characterized by high basal acid output, BAO, and maximal acid output, MAO ratio. So the BAO to MAO is greater than 60%, and that's pathogenomic for the disease. Normal would be between 5 to 20%. Characterization of gastrin levels. So fasting gastrin levels, gastrin being measured as a diagnostic tool for evaluating ZE syndrome. So fasting gastrin levels with ZE syndrome is between 2 to 2,000 times normal. Serum gastrin levels are greater than 1,000 nanograms per liter with gastric acid hypersecretion, diagnostic of gastrinoma and ZE. There is a secretin method that is used for evaluating gastrin. So a 2 units per kilogram bolus of secretin is administered intravenously after an overnight fast. So the patient doesn't eat overnight. In the morning, they go get an IV of secretin, and then serum levels of gastrin are determined at 0, 5, 2, 5, 10, and 15 minutes. Increased gastrin interferes with the salt water absorption, and that causes the diarrhea that's characteristic of the ZE syndrome. Increased gastric acid in the duodenum interferes with fat absorption, and that causes steatorrhea. Steatorrhea is excessive fat in the feces. So greater than 7 grams per D is indicative. Gastrin analysis. So gastrin is analyzed using an immunoassay. So once we do the secretin method that we described previously, then we will evaluate those serum samples for the presence of gastrin. So gastrin is measured by immunoassay. It's reported in G17 equivalents. So G17 is the reagent, and it's used as a calibrator in the assay. The gastrin form G34 is most common in patients with gastroma. Sampling considerations: it is unstable in serum even when refrigerated, so it has to be kept at -70 for long-term storage. Once we collect the specimens, we have to centrifuge them right away, remove from the clot, divide them into 2 aliquots, and freeze until the assay is performed. Assay immediately upon thawing, do not refreeze. Blood must be collected into a heparin-containing tube, separated in a refrigerated centrifuge, and frozen within 15 minutes of collection. Basal acid output, or BAO, and maximal acid output, or MAO. BAO measured as a 1-hour test after an overnight fast, followed by a 1-hour stimulated test, the MAO. ZE syndrome displays extreme acidity. Gastric peptic ulcer is associated with normal secretory volume and normal acid output. So if you do see an excessive amount of acid, it could be ZE syndrome. But a duodenal peptic ulcer has increased secretory volume and increased acid output. Not quite as high as ZE syndrome. Pernicious anemia is anacidity, so the absence of acidity. Stimulation tests include the secretin one that I just talked about and pentagastrin. Interpretation of increased gastrin levels. So there's appropriate or inappropriate. Appropriate means that the acid secretion is low and antral G cells function normally. Gastrin appropriately elevated as G cells increase in the number. Hyperplasia. Atrophic gastritis, pernicious anemia, and renal failure are all indicated with appropriate gastrin levels. Inappropriate elevated would be if acid secretion is normal, fundic mucosal normal function, and gastrin is elevated. When gastrin is elevated, then that could indicate a gastrinoma, an isolated retained antrum after gastric surgery, or a primary gastrin cell hyperfunction. Diarrhea, an abnormal increase in one or more stool characteristics, so daily weight, liquidity, or frequency. Results from solute malabsorption, motility disturbance, secretion of fluid into the intestine, high amounts of poorly absorbed osmotically active solutes, intestinal ion secretion, increased epithelial permeability due to the obstruction or inflammatory or infectious disorders of the bowel, or replacement of absorptive epithelium by crypt epithelium. Classification of diarrhea. There's osmotic and secretory. Osmotic is caused by poorly absorbed osmotically active solutes. So when you stop eating, it goes away. Carbohydrates or divalent cations, Mg or SO4, could be indicative. Secretory diarrhea. Inhibition of ion absorption or stimulation of ion secretion, and it persists even when fasting. Characteristics include stool osmolality accounted for by normal ionic constituents. The condition persists after fasting, and there is not pus, blood, or excess fat. Causes of secretory diarrhea could be bacterial related. So there's enterotoxins and bacterial exotoxins. Enterotoxins are incorporated within the cell itself. So the more you destroy the cell, the more these toxins are released. Exotoxins are actually excreted out by the bacteria. Sometimes with the exotoxins, you can see that the bacterial cells have been killed, but the toxins are remaining on the surface of the food. So for example, if you have a turkey that's thawing at room temperature instead of thawing in the fridge, sometimes there's some staph bacteria that is on the surface of that turkey. The staph bacteria deposits or produces and deposits those exotoxins, and then you cook the turkey. And even though cooking kills all the bacteria on the surface, those exotoxins are still viable and still left behind from the bacteria. And then when you consume it, it can cause the diarrhea. Those types of exotoxin-related diarrhea are typically self-limiting, and they only usually last about 8 hours. Tumor production of secretagogues, i.e. vasoactive inhibitory peptide, alteration of electrolyte, fluid movement, bile acids, over-the-counter laxatives, inflammatory bowel disease, or parasitic infections, decreased solute absorption due to the loss of mucosal transport. So celiac disease, altered mucosal morphology, or monosaccharide malabsorption, isolated transport defects. Werner-Morrison syndrome, a watery diarrhea syndrome, watery diarrhea, hypokalemia, so low potassium, and hypochlorhydria, or achlorhydria, sometimes seen as part of multiple endocrine neoplasia or MEN syndromes, usually due to pancreatic non-beta cell tumor secreting VIP. VIP causes vasodilation with facial flushing and increased intestinal blood flow, induces watery diarrhea, and inhibits gastrin secretion. Diagnosis is by eliminating other causes of diarrhea, usually with hypo or achlorhydria. Diagnosis is confirmed by elevated levels of VIP. Other disorders of the large intestine: blind loop syndrome, regional outpouchings in the large intestine. It's caused by inflammatory or anatomical disorders. Material becomes trapped, allowing bacterial overgrowth. This leads to the excessive breakdown of bile conjugates. Deconjugated material cannot be reabsorbed, and it can lead to diarrhea. To test for this, we do the bile acid breath test. The bacteria deconjugate bile, so we take a C14 labeled glycinocolate administered orally. That is then converted to carbon dioxide by the bacteria, and carbon dioxide in the breath is trapped in an alkaline solution, with subsequent detection of radioactivity. Sensitive indication of the presence of bacterial overgrowth. Inflammatory bowel disease, idiopathic inflammatory disorders present with abdominal pain, diarrhea, and malabsorption. Ulcerative colitis affects the large intestine, while Crohn's disease primarily affects the small intestine. In ulcerative colitis, you have atypical perinuclear anti-neutrophil cytoplasmic antibodies, so ANA antibodies, may be present, and it's about 90% specific to this. In Crohn's disease, we have autoantibodies to Saccharomyces cerevisiae may be present, and it's about 95% specific. Saccharomyces cerevisiae is a type of yeast, and that's the yeast that we use in baking and brewing. Evidence, autoimmunity, and familial predisposition. Malabsorption versus maldigestion. So in malabsorption, the GI tract is impaired and it's unable to absorb a variety of nutrients. While maldigestion, there's something wrong with the digestive process that leads to an inadequate absorption of nutrients. Most commonly caused by pancreatic insufficiency, also with inadequate pancreatic enzyme activation associated with achlorhydria or excessive acid production, inadequate bile production or secretion. It typically leads to fat malabsorption and steatorrhea. If the fat's not absorbed, then it's released in the stool. Malabsorption syndromes, so result from interference with digestion, absorption of food. Characterized clinically by loose stools typically containing fat or steatorrhea, loss of weight or failure to gain weight in children, secondary deficiencies in fat-soluble vitamins, bone disease, prolonged clotting times, poor night vision, neuropathy, caused by pancreatic insufficiency, achlorhydria leading to inadequate pancreatic enzyme activation or inadequate bile production or secretion. Steatorrhea. Stools are characteristically pale, bulky, and greasy with a repugnant odor. It's important to distinguish clinically stools from those due to other causes of diarrhea, the amount of fat present, and the specific cause. So causes include ZE syndrome, increased duodenal acid, abnormal bile output, pancreatic insufficiency, intestinal mucosa impairment, diseases of the large intestine causing interruption in bile salt, enterohepatic circulation. Fecal fat determination, so fat screening, evaluation of weight and appearance of stool. So pale, frothy appearance is diagnostic of excess fat. Stained specimen with a fat-specific stain. Microscopic evaluation for the presence, size, and number of fat droplets. 10 times as many fat droplets seen with steatorrhea. The diameter of the droplets correlates with total fecal lipids. Perform a steatocrit, which is the percentage of fat quantified in a random sample. So with a steatocrit, the sample is homogenized with sand and 2 volumes of water. The aliquot of mixture is centrifuged in a microhematocrit tube. Patients with steatorrhea have 3 layers. The lower layer is the non-fatty fecal solids, the intermediate is the liquid layer, and the upper fatty layer is expressed as a percent of total fecal solids. In the absence of steatorrhea, the upper reference level is 2.1%. Anything higher than that would be consistent with steatorrhea. So the quantitative estimation of fecal fat for definitive diagnosis of steatorrhea, you need to quantify it. This is performed on a 72-hour collection. For 2 days prior and during collection, the patient must include 100-gram medium-chain triglycerides in their diet. You weigh the sample, perform the analysis on well-mixed aliquot of 3 days of collection. Quantitated by near-infrared reflectance analysis, or NIRA. The measurement of radiation scattered by surface of spot fecal sample. Variations in wavelength allow determination of dry weight, total nitrogen, total fat, and hydrolyzed fat. Separate determination of total fat and hydrolyzed fat allows indication of the origin of steatorrhea. Other malabsorption disorders, so celiac disease. It's due to immunologic response against wheat gluten. It's characterized by antibodies to gluten and enzyme tissue transglutaminase. Symptoms are progressive weight loss, diarrhea, flatulence, and abdominal distension. Stools may be bulky, pale, foul-smelling, and floating. Osteomalacia and osteoporosis may develop. Disease may be subtle. It manifests as anemia and iron deficiency, folate, or by vitamin B12 deficiency. Definitive diagnosis by intestinal biopsy. Ulcerative colitis. It's a chronic inflammatory disorder with an unknown etiology, so we don't know what causes it. Most often affects mucosae of the rectum, left colon. Characterized by intermittent attacks of severe diarrhea associated with rectal bleeding lasting for several weeks. It leads to anemia, water and electrolyte imbalance. Toxic megacolon results when the pathology extends into the muscular wall of the colon. It leads to shock, fluid and electrolyte depletion, and further leads to renal failure and cardiac arrhythmias. Crohn's disease, chronic inflammation of the intestine with an unknown cause. The distal ileum and colon are most often affected. The entire intestinal wall is affected. Progress to ulceration, fibrosis with contraction and obstruction, fistula, formation between loops of the gut or gut and other organs. Complications, malignant intestinal neoplasms, arthritis, abnormal liver function, renal involvement, increased risk of stone formation, or generalized malabsorption. The screening approach for the diagnosis of malabsorption, clinical signs and symptoms in at-risk populations. Laboratory screening is not sensitive, but we can use serum albumin, calcium, vitamin B plus or B12, peripheral smear analyzing for macrocytosis and iron deficiency anemia, the lactose tolerance test, and D-xylose absorption test. In the D-xylose absorption test, D-xylose is absorbed passively in the small intestine. So it is a pentose sugar that does not need to be digested before it's absorbed. So it's independent of pancreatic enzymes. The amount recovered from the blood or urine within a specified time interval is used to evaluate mucosal absorptive capacity. So we have a patient consume D-xylose, and then we see if the D-xylose is absorbed through the intestine into the blood. Then we'll take blood samples to see if we have D-xylose being present in the blood. And that can give us a clue as to the integrity of the surface of the small intestine. Low absorption observed with intestinal malabsorption, especially in the jejunum. Celiac disease, tropical sprue, Crohn's disease, blind loop syndrome are all indicated with low absorption. Essentially normal in malabsorption due to pancreatic insufficiency. So because the pancreas isn't involved, if there is pancreatic insufficiency and D-xylose levels are evaluated when it's consumed, they will be measured in normal concentrations in the blood after. Colon cancer. So malignancies of the colon, rectum account for over half of all cancers of the GI tract. Screening is most effective at curing the disorder or at preventing the disorder. CEA, tumor marker for prognosis and monitoring of treatment or recurrence. So we typically screen for colon cancer using a colonoscopy that looks for anything abnormal in the colon. If there are abnormalities in the colon, a biopsy is taken, and that biopsy is sent for evaluation in the lab. We look at it under a microscope and look for neoplasia or dysplasia. If that's noted, then we start the patient on treatment. Once treatment begins, we take a baseline CEA level, and that will determine the prognosis of the patient or the outcome of the patient. Higher levels of CEA are associated with poorer prognosis. Once the colon cancer is treated, we can then monitor the treatment using CEA. So we do repeat measures of CEA. And then once it's gone, we can tell if it's come back by measuring CEA. Occult blood, patients with colon cancer have small amount of hemoglobin in their stool, greater than 2 milligrams per gram of stool. The Guillac procedure is also used. Dietary interferences, iron and peroxidases in red meat and various plants. Withhold red meat for several days prior to the procedure. Allow the samples to stand for 2 to 3 days. Rehydration of dried samples prior to testing reduces false negatives but may increase false positives.